Welcome to those in the room and to those online. My name is Jennifer Wargo, and I'd like to welcome you to the new chapters in the immunotherapy story for melanoma with collaborative care and next steps with adjuvant and neoadjuvant therapy, sponsored by Peer Review. And so tonight's panelists include myself, as well as Charlotte Ariyan and Hussein Tawbi. And I'd like to thank Peer Review for providing this session, as well as Bristol Myers Squibb and Merck and Company for providing the educational grants for this symposium. If you haven't already, please do complete the pre-event survey and then also look out for additional follow-up polling during the presentation. It's going to be a lot of fun. And submit your questions. We already have some excellent questions, but we'd love more, and we'll answer them during the Q&A session. And so you can visit us at peerreview.com/melanoma24. Again, as described with the iPads, you can actually view the slides and practice aids now and download them after the event. And so, please peruse that when you have a chance. So here we're going to kick it off with a polling question. So everyone get ready. So in your practice, which of the following represents a challenge or ongoing question related to the management of patients with resectable or potentially resectable melanoma? And select all that applies. Number one is determining the best candidates for adjuvant therapy in the setting of stage 2 melanoma. Number two is the role of sentinel lymph node biopsy prior to deciding on adjuvant immunotherapy. Number three, determining candidates for neoadjuvant immunotherapy. Number four, deciding on single agent versus combination neoadjuvant immunotherapy. And number five, the future role of adjuvant immunotherapy combinations, including PD-1 CTLA-4, PD-1 LAG-3, PD-1 plus this individualized neoadjuvant therapy or vaccine therapy. And so go ahead and answer that question.
Online, are they answering too?
All right, so here are the results. So close to 40% of people said determining the best candidates for adjuvant therapy in a stage 2 setting. Some of the most popular, of course, were the future role of adjuvant immunotherapy combinations, as well as determining candidates for neoadjuvant immunotherapy, and also sentinel node. So I think there's a lot of room for you to learn. I think there's amazing content during the course of this. We're making it very interactive, and so I think you'll get a lot out of the next 90 minutes. And so why are we here tonight? And what are the unmet medical needs in resectable melanoma? And so just stats from a few years ago, in a study of over 300 patients with stage 3 melanoma in the 2018 US Oncology Network electronic health record database, most of the patients, actually almost 3/4, actually received a watch and wait approach, regardless of substage. Pretty interesting data there. And then in a larger set from the National Cancer Database of over 8,000 patients with stage 3 melanoma, only 28% of patients received immunotherapy after surgery. And so, boy, times have changed. So what you'll see is in the next 90 minutes, you're going to see, really all the advances, and even more, even than last year, I think, when we were here. And so, again, if we think about how about stage 2, and so the National Cancer Database assessment of stage 2B and 2C melanoma patients who underwent resection and sentinel lymph node biopsy, again, over 8,000 patients with pathologic stage 2B, 2C. Utilization of adjuvant immunotherapy in this subset was actually quite low, and treatment disparities, although this was highlighted within this study, there were some treatment disparities by gender, age, and travel distance in here. And so I think an important question is, how will improved adjuvant options in stage 2 disease inform future treatment trends? And Dr. Tawbi is going to teach us all about that. And so what are our goals for today? First, to augment your understanding of guidelines and evidence supporting adjuvant and neoadjuvant immunotherapy in a range of resectable melanoma settings. We're going to use case presentations to really highlight all of this to equip you with the skills that you need to plan adjuvant and neoadjuvant treatment based on PD-1 monotherapy or immune-based combinations, and we'll go over several different combinations. And finally, to provide you with guidance on how to address dosing and safety considerations associated with immunotherapy in surgical settings. And so with that, I will kick it off to Dr. Hussein Tawbi, who will speak to us on changing the narrative in stage 2 melanoma with adjuvant immunotherapy. Notably, Hussein is the deputy chair and professor in the Department of Melanoma Medical Oncology at MD Anderson and is the co-director of the Brain Metastasis Clinic and Program, a close colleague and friend. And so with that, I'll kick it over to you, Hussein.
Thank you. Thank you so much, Jen. Thank you. It's really an honor to be here with these two amazing ladies, investigators, scientists. And if you're wondering why I'm cornered in the middle, it's because they both actually said they will protect me from a room full of surgeons. I'm hoping this approach will be able to run fast enough. But anyway, so what we're going to talk about today, and I think when we discuss early stage melanoma, basically resectable melanoma, this is going to be most of what we're going to talk about. Really, it comes down to a discussion around risk. I mean, I say to my patients that surgeons cure way more melanomas than I do, and that's the truth. But then there are patients that have melanoma that recur and die of their disease despite surgery, and that's the idea of where we're going to be able to introduce some of the systemic therapies that we have to do this. So Jen and Charlotte and I decided to inflict upon this nice lady named Nancy a bunch of really different scenarios. So bear with us. We're going to start with Nancy finding this really ugly melanoma on her forearm, I believe, upper arm. So it's a T3B ulcerated, 3.9 millimeters. We chose it to be short of being 4 millimeters. No palpable lymph nodes, so no clinical stage 3 disease, with a wide excision and sentinel lymph node biopsy that was negative. It is a BRAF mutated melanoma. So this is kind of the first setting the stage. So for a patient like this, what would you do? Would you observe or would you treat with adjuvant immunotherapy? And as you think about this, when do you actually pick up the phone and call your friend medical oncologist, if you have any of those, and ask them what options they have for a stage 2 disease? So really, as I said, the question comes down to risk. And the best data that we have in hand is actually from the AJCC staging. And it's a really important set of data. On this graph, you have over 5,000 patients. And you know, when Jeff Gershenwald led this analysis with many collaborators across the globe, a very important aspect of AJCC 8 was actually that it was a very clean data set. Patients were required to have had a sentinel lymph node biopsy, so their staging was really kind of put in the right, like with all of the kind of determination of sentinel. Not a single one of those patients did not have a sentinel, so we know exactly in which category they sit. And when you do that, you realize that, again, for stage 3 disease, let's look at stage 3 for a minute. Stage 3, the substages of A, B, C, and D, this is, again, 5,000 patients or so. This is melanoma-specific survival, meaning that every death that occurs on this is of melanoma. So that's really important. And if you look at this, the first thing that jumps at you is patients with clinical stage 3 disease. That will be 3C and 3D patients. Look at the survival, 25% survival. 75% of those patients die of their melanoma. That's how bad this is. So it's a really bad disease, and we really have to think about ways to improve that outcome. And then when you look at patients that are stage 2C, you know, when we kind of start to be in this area, stage 2C patients are actually almost identical with stage 3B. So it always kind of takes a minute. We look about the numbers a lot, but if you think about it, when you treat, you guys probably treat breast cancer and lung cancer. If they found a 2 or a 3 centimeter lesion, that's still kind of probably stage 1. You know, in melanoma, we measure things in millimeters. Millimeters are capable of killing patients, and a thick melanoma, like a 2C melanoma, is capable of killing, again, almost 25% of patients. So that is the kind of the background in which we make those decisions. And so it comes down to the idea, if we're going to be able to do something for those patients, I will tell you, not only do surgeons cure more patients with melanoma, I also overtreat a bunch of patients in the adjuvant setting. By definition, You guys cure about 37%, for instance, of stage 3 patients. So every time I want to come and treat a patient with adjuvant therapy, I know that I'm over-treating somebody. But the question I ask myself is, how many patients am I able to cure? So this idea of the number needed to treat, I don't know. We use it a lot in medicine, but somehow not in oncology as much, right? If you go to your PCP, they're going to try to push a statin on you. I'm sure half of the people in this room are already on a statin. You know how many what the number needed to treat for statins is to actually prevent one heart attack? 60, 60. And so all of the muscle aches that you're having from that, think about it. It's 60 patients to avoid one heart attack. So when you look at something like stage 3 melanoma here with a survival of the melanoma-specific survival of 50%, we now have adjuvant therapy that can decrease that risk by a half. So the absolute risk reduction is 25%. That's massive. And the number needed to treat is only 4. So with 4 patients you treat, you can cure 1, which is really amazing, which is why in stage 3, we don't really think that hard. We do, but it's easier to think about how much benefit you're giving those patients. When you're talking about the stage 2 patient, or we're going to probably talk soon about stage 3A, for instance, if your risk is only 10%, the absolute risk reduction, despite the fact that it's a half, it's only now, the relative risk reduction is a half, the absolute is now 5%. So you're going to be treating 20 patients to save 1. And you know what? The number needed to harm is exactly the same, because these drugs that we use, targeted therapy, immunotherapy, they all have a defined toxicity rate, which is about 17% for patients with.
Advance with that.
Oh, thank you. So here's the calculus. So if we take this patient and her stage 2B disease in this case has about a 20% risk, so her absolute risk reduction with adjuvant single agent PD-1, which is about, the hazard ratio for that is 0.62, so about a 28% decrease, 38% decrease in the risk of death. It's 8%. Now, again, take a minute. With breast cancer, if you can decrease the risk by 3%, it would be malpractice to not give those patients 6 months of chemotherapy and Herceptin for God knows how long, right? So it's still a pretty substantial risk reduction here at 8%. And again, the toxicity about 17%. Now, true enough, though, for patients with melanoma that recur with metastatic disease, we do have effective therapy. We do have therapy that can still cure about half of those patients in the metastatic setting. But again, I don't know which patient would be willing to live with kind of the diagnosis of metastatic melanoma and may be cured with all of the toxicity that comes in the metastatic setting. So it's an approach we have, but not sure that we want to rely on it primarily.
Oh, can you go back to that slide for a second? Because I think one point that we did want to raise is, how about if she didn't see a surgeon, or she saw a surgeon and didn't have a sentinel lymph node biopsy?
So I think that's a discussion that we're going to need to have. And it's interesting. I know that our colleagues in Europe are kind of going farther and farther away from sentinel lymph node biopsies. So this would be, if you do it basically purely on clinical evidence without a sentinel lymph node biopsy, you will put her at stage 2B. If you actually do the sentinel and she has 2 positive lymph nodes, immediately you're all the way up to 3C. Your risk of this recurrence is now over 50%. Your absolute risk reduction now is a massive 30%, right? So in that case, again, the grade 3 toxicity becomes, you look at it now, the number needed to harm is about 6 patients, and then the number needed to treat to cure a patient is a lot higher, obviously. Now, we have toxicity with BRAF MEK inhibitors as well. It's about 25%, but we know that with those, we don't actually have long-term toxicity.
And if we can pause for 1 second, because I think, let's just revisit that, because I think there are people who are, especially in Europe, like you said, who are trying to go away from doing sentinel lymph node biopsy. Charlotte, do you have an opinion?
Yes. Is this on? I mean, so the sentinel lymph node biopsy is primarily a staging procedure. We heard today, if there's any survival benefit, maybe it's only in people who have very, very early disease, and it's a small amount of people. But I think this multidisciplinary discussion with the medical oncologist and the patient. If it's important to the patient to understand their risk reduction and their full spectrum of disease, which I think most people feel that, because these medicines have some toxicity, right? And it helps them understand where they sit in the risk spectrum, I think we should do it. It's not that invasive of a procedure. It's pretty well tolerated. And so I'd say a majority of people, we end up doing it for. And I think it helps our medical oncologists. I don't know if you feel like it helps you, but
Oh,
you know.
absolutely. I mean,
yeah.
I think when we see a patient like Nancy at
Yeah.
3.9 millimeter, I tell them that my rule of thumb is about 10% risk per millimeter until I get the sentinel lymph node biopsy, because if it's negative, you just immediately have that risk. If
Yep.
it's positive, you actually add 20% to it. So that's kind of my rule of thumb of doing things, and it's a huge difference, as we're seeing here. You know, 20% versus close to 55, 60% if she has even 2 sentinel lymph nodes with
Right.
microscopic disease.
Would you actually treat someone who didn't have the sentinel node staging?
That's a very tough question. I'm really very evidence-based, and I find it hard. And what happens in practice is some people do go for a sentinel, and it's not, you know, found, or you don't know the answer, even if people try. So in those cases, it's a tougher discussion. You just have to go with what you know. So the risk reduction, the absolute risk reduction is still the biggest discussion we have with those patients.
I can tell you that people who are coming to us from the community with the dermatologist excising the primary, no sentinel node, sent to MedOnc for adjuvant therapy, most of the medical oncologists are sending them to us then to say, do a delayed sentinel node. We want
Same.
to have this
Yeah.
conversation. Yeah.
And I'm going to talk a little bit later. We have some slides about this. Of course, we also have people that come with the gene expression profiling done.
Yes.
And some people, you know, kind of going with that as, oh, you shouldn't do a sentinel lymph node because a person is a class 1 or something that is low risk. So I'll address that a little bit later.
Or the person who comes with a very low risk melanoma that says they have a very high risk of recurrence and they want adjuvant therapy.
Yeah.
Yeah,
So
yeah.
let me give you tell you
primer on
already
that.
the answer. These
Yeah.
are not ready for clinical practice. They're not validated enough to make those decisions, and you'll see that a little later in the talk.
Oh, and advance with the.
Oh, actually, right here.
Yeah.
Sorry.
Use that to advance in the.
Oh, I'm sorry.
No,
I'm
it's
sorry.
okay.
I'm messing things up. See, I tell my patients they're lucky I'm not their surgeon
Yeah.
because I'm really clumsy. So the gene expression profiling, I think, again, we go back to the idea that we do love the idea of somehow being better at risk stratification.
Yes.
It's kind of a little difficult sometimes, even when you're sitting with your fellow and talking about the millimeters and the ulceration. And really, the mitotic rate is important, but it's not part of the staging and all of this stuff. So it'd be great if we can run something that tells us. And I have to give, you know, there are 3 now that are in practice, and I have these 3 listed here. I have to give them the benefit of the doubt that they're trying, and I think there's some value to trying to learn from the tumor and its gene expression profile, whether it's going to recur or not. But I will tell you that those are mostly done in retrospective studies. They haven't been prospectively validated. There's a lot of issues. For instance, what you see, the list I have on the left is the genes involved. Guess what? Those 3 things that are in practice, there's no overlap in these genes. It's an entirely different set of genes in each of them. So it kind of makes you wonder, is it really telling us about biology? So it's a good idea, but it needs a lot of work to get there. And you see on the right is the recommendations from the melanoma prevention working group that really looked at these gene expression profiling, decided first that we can't just give people like yes or no, good or bad. We know that there's going to be kind of gradations to this. We know that we need to, and they also need to take into account the actual ulceration and stage and you know, the mitotic rates and other things that are usually included in our clinical decision making, and they're not included as part of these gene expression profiles. They do need to be in a, you know, kind of a wider spectrum of disease. If you read this paper, I really recommend you do. You know, in stage 2A, for instance, they're pretty good, but in stage 2C, they lose their ability to actually predict. So you don't want something that is not robust enough, and it can work in all risks of the patients. So the melanoma prevention working group, basically the consensus at the time is that the data does not support the routine use of these signatures, and I think they're going to be tested. We'll talk about this in a minute. They're going to be tested in some trials, and I think they may have value. But I implore you, and I think my colleagues here would agree, don't make your decisions on sentinels based on that, and surely don't make your decisions on adjuvant therapy based on these as well. Now, we are trying, and I will also show you, this is data from Checkmate 76K. So this is the study of nivolumab versus placebo in stage 2 patients. I'll be showing you the actual clinical data soon, but these efforts are ongoing to try to figure this out. How are we going to learn from the tumor what will actually, which patients are going to benefit and which patients are not? And what you see in here is these are the factors that ended up being actually significant. So you can look at CRP. You have tumor-specific factors like the TMB, the tumor mutational burden, the interferon gamma signature, but a bunch of clinical pathologic factors, age, sex, BRF status, mitotic rate. So a lot of these things that, again, intuitively make sense, and they did come out as potentially predictive of RFS. And then they actually showed a little bit more benefit for the with Nivo versus placebo, as you would expect with things with higher TMB with interferon gamma signature. But two things. First, these are useful things. They're starting to show us some things that we expect and maybe some things we don't. But they're also not ready for prime time. I can't look at this and say, okay, I'm going to test all these things and figure out if I'm going to treat my patients or not. Unfortunately, not there yet. And the clinical pathologic factors are so valuable, and this is a really important study. It was just published in JCO by the MIA in collaboration with the US and actually MD Anderson in the Netherlands as well, where they took all of these factors that we were just talking about. Age, breast low thickness, ulceration. You'll see here sentinel lymph node status is actually not performed, ends up being high risk, and they came up with this nomogram. And it actually did classify patients into 3 categories. And what you see here on the right is basically the MIA data and then the validation from the US and the Dutch groups. I mean, it's almost identical. So it's really impressive. And again, look at this, the sentinel status here, not performed, gives you extra points, higher risk. So think about that. The mitotic rate is important, and then you can predict survival that way. So this may be a really interesting thing. It's just got published. I haven't used it in my practice yet, but for the purposes of this talk today, thank you, Carmine, we actually put in the Nancy's data into this, and it's an online calculator, almost similar to the breast cancer calculator. And for this lady, the 10-year survival is actually 65%. So her risk of recurrence or death from melanoma is even higher at 35%. Validates my 10% per millimeter, right? almost there. So it's a really high risk for this lady.
Oh, can you go back to that for a second? I really want to highlight that this is easy to use, right? And this is data that patients are asking about, right? Mm-hmm. And it's data that can help you guide next steps in therapy. So, but it's very easy to use. It's very user-friendly and very informative for patients.
And validated, at least in these 2 cohorts that were used. Okay, I'm sorry, I keep messing up the clicker and the...
I just want to add one other thing, though, since we're on the calculator. Go back. At the bottom, just so you can see, is the confidence intervals. So it'll say 65% with the confidence interval, 55 to 73%. And when you get down to the early levels, which is where everyone is wondering what to do, the confidence intervals are huge. So it's hard. We need to keep feeding data into these models to make it a little tighter in those.
And maybe AI one day?
And maybe AI, yeah.
So this is just kind of the guidelines, just highlighting the fact that adjuvant immunotherapy is now category 1 in the guidelines. And again, this is a discussion of wide excision. Do you do the sentinel or not? That's a discussion I'll leave to the surgeons. I want my patient with a sentinel when you send them to me, just for the record. And then, again, pembrolizumab and nivolumab are currently category 1 for stage 2B and 2C. So let's go through some of the primary data just so that we can kind of be speaking kind of from the same page here. So this is Keynote 716. This was the first study that specifically took patients with 2B, 2C disease and randomized them to pembrolizumab or placebo. Massive trial. This is 1,000 patients worth. And so the thing about adjuvant therapy, I think it's very important to give these data time to mature. It does, some patients are known to recur late. So what we saw in the original data, there was some questions about the different T stages, and maybe there's more benefit in kind of specific T3s, and maybe T4s don't benefit as much. But look, as soon as we waited, gave this some time to mature, if you look on the right, all of these subgroups, essentially almost every one of them does not cross 1. which is already, once you do subgroup analyses, be careful because these confidence intervals, back to Charlotte's point, immediately expand, and you have to really be careful. But, I mean, the benefit looks pretty consistent across all T stages now that the data is a bit more mature. And this is with RFS. The other thing we think about in adjuvant therapy, specifically with stage 2, is that obviously patients can recur locally, so does every recurrence count the same? If, again, I can send them back to Jen and Charlotte and they can cure them with just a therapeutic lymph node dissection, right? So the idea here is that we want to prevent distant metastases. That is kind of our surrogate for, death of melanoma. And obviously there's great benefit. The hazard ratio is 0.59. And mostly all of the subgroups do pretty well. Again, be careful with these that cross 1 because of just the confidence interval and the small sample size. It doesn't seem like a lot of events have happened for stage T3B patients. In terms of toxicity, again, pembrolizumab, nivolumab, very consistent every single time. We see almost in every setting about 15 to 17% grade 3/4 adverse events. They're all immune-mediated adverse events. Checkmate 76K, of course, BMS, not to be overdone by Merck, ran this study. It's a slightly different trial. It's about the same population, but it actually is a 2-to-1 randomization, so there's kind of less patients on the control arm, so to speak. And again, when you do statistics, the control arm is really what determines your power, and it's very impressive. The pattern of recurrence is slightly different, and I think when you see those dips every 6 months, remember those patients are stage 2, so they actually get restaged every 6 months, and that's where obviously you find the lung met and the liver met. So the hazard ratio looks better than pembrolizumab, but again, I don't consider those two drugs to be any different from each other literally in any setting, so I would probably ascribe that to just the slightly different populations. But point is, it works. It decreases the risk by about a half. And again, in all T categories, it doesn't matter. And BRAF mutated or not, it doesn't really matter. So there's consistent benefit with these drugs across the board. This is the DMFS, again, to confirm the fact that we are capable of decreasing the risk of distant metastases. Toxicity in this study, nivolumab looks a little less toxic, but this is, again, trial-related. I can tell you when we ran phase 3 trials in the metastatic setting, we're actually just getting better at treating toxicity, I think. The rates are just decreasing. I think we stop sometimes when we have a patient that's coming in with a, kind of a little bit of a cough, and they'll tell you, my nephew was visiting and they have a virus. I'm like, no, I'm not treating you today. I'm just going to wait a couple of more weeks, get a chest X-ray. So we actually end up kind of sometimes holding before pneumonitis sets in and retreating. So I think we're really getting better at that, and that's probably shaving off a few percentage points. So let's go back to this. So I hope that I tried to, that I convinced you over the course of this discussion that the question in adjuvant therapy is what is the risk of recurrence and how can we mitigate it? And what is the absolute risk reduction in the context of the same number needed to harm across most of our therapies? How many patients are we going to able to cure with this treatment? And so being able to classify patients in the right spot, get a really accurate risk assessment if we can, that's probably what will help us drive the best discussions with those patients. And so just in terms of, I saw from the online questions, people are really interested in what's coming in adjuvant therapy. So I'll tell you, the first study is a really interesting one. I was mentioning how the gene expression profiling is being considered in a prospective way. This is the Nivo-Mela trial, is a study that is running in Europe, mostly driven by the German group, where they actually have that melagenics gene expression profile, and they're using it to, if it's a low risk, patients are going on observation. If it's a high risk, they're being randomized to treatment with Nivo versus observation. So really cool study. And it'll be interesting to see whether kind of observation in both arms looks the same or not. I'm actually more interested in that piece than the effect of nivolumab. And then, everybody learned from the Keynote 054 and then Keynote 716 that they needed, 1,000 patients in each trial, but this design was exactly the same. So now all of the combination therapy that are coming into the adjuvant setting, they're including both 2B, 2C, all the way to resected stage 4. So every one of these combinations is going to be tried in the stage 2 population as well. So you have the TIGIT combination plus PD-1 for that Merck is running, vibostolimab and pembrolizumab. And there's the nivolumab relatlimab trial that we ran that was in stage 3, by the way, that was not in stage 2. And now this is cemiplimab and fianlimab, the LAG-3 plus PD-1 from Regeneron, and that's including stage 2 patients. So with that, I will pass it back to our moderator, Dr. Wargo. Thank you.
All right. So now it's time for our follow-up poll. So going back to that scenario, rethink your choice. What strategy would you pursue when attempting to decide on next steps for a patient with a T3B ulcerated 3.9 millimeter melanoma of the upper arm? This is our patient Nancy. So would it be number 1, observation? Would it be number 2, adjuvant PD-1 therapy?
With a positive sentinel node or a negative sentinel node? Which
This
part
one
we
is-
didn't say yet because the
Okay.
question is, do you
Oh,
do a
yeah,
sentinel?
sorry.
Yes, yeah. So observation,
Tricked you.
I
adjuvant
know. You
PD-1.
should trick me, I didn't read all the way down.
Do you do gene expression profiling? I think not. Plus or minus sentinel node biopsy.
But they can vote.
Yeah,
Yes.
but you can make your own choice.
Yeah.
Sentinel lymph node biopsy, then observation, sentinel lymph node biopsy, then consider adjuvant
Yep.
PD-1, or I'm not sure. So this is your choice. Vote your conscience.
Surgical population.
All right.
There we
So
go.
sentinel lymph node biopsy, then consider adjuvant PD-1. I think that's a pretty darn
Good.
good answer. Yeah. Still.
93%. I think my night is over. I should
Yeah,
drop
that's
the
right.
mic.
Drop the mic, Hussein. But yeah, so really great. Still some people looking at the gene expression profiling, and I think it's not quite there yet, but I think important to run that trial, and we'll see. Okay, and then reassessment here. Can you pinpoint the statements that reflect updated outcomes across subgroups from phase 3 studies testing adjuvant PD-1 therapy in stage 2B and 2C melanoma? So 1, I am not familiar with updated evidence from these trials. Number 2, adjuvant PD-1 improves RFS but not in T4 disease. 3, adjuvant PD-1 therapy improves RFS but not in BRAF mutated disease. Or 4, adjuvant PD-1 therapy improves RFS across subgroups, including in BRAF mutated and T4 disease. Maestro. All right, well, I think pretty good there. And if you look at the pre-post, I think insights have been gained. And so I think adjuvant PD-1 therapy improves RFS across subgroups, including in BRAF mutated and T4 disease. So your job is done here, Hussein.
Yeah. No, there's more. There's more.
Yes, there's more. And on that note, we
Yeah,
had
yeah.
the distinguished honor of having Dr. Charlotte Ariyan, who's the co-lead of melanoma at Memorial Sloan Kettering Cancer Center, and the Carol Basak Lowenstein Chair Research Attending at MSK in New York, who's going to be discussing with us writing the next chapter, adjuvant standards and emerging combinations. Charlotte, over to you.
All right. So we're going to move on a little bit really into stage 3. It was a kind of a launching from stage 2 to stage 3 and hoping to keep this interactive as well, to keep everyone awake here. And so we're going to start with another case with Nancy. Poor Nancy. Okay, so here's Nancy, 48-year-old woman, now presenting with a melanoma of the upper arm, 2.1 millimeter non-ulcerated, and does have a wide excision sentinel node, 1 out of 2 nodes with scattered cells. You can see in the picture there, pointed out by, there's some tumor cells that also stained by IHC over here. So this gets to the question that she's a stage 3A melanoma and less than 1 millimeter in tumor burden. So what are our best choices here? We're going to discuss this, observation or adjuvant immunotherapy, and what's the nature, again, of our collaboration when making decisions about adjuvant therapy in stage 3 disease. So we're going to look a little bit more at the data, but just to highlight, when we look at these adjuvant trials in stage 3 disease, these trials excluded patients who had the tumor burden in the lymph node was less than 1 millimeter in size. So do you still use that in your clinical practice, that assessment of tumor burden as a risk factor?
Yeah, I mean, it's interesting because it goes back to kind of the FDA, right? The trials came out, they were very specific. You had to have a 1 millimeter and the approval or stage 3, period. So a patient walks in the room and they're like, oh, we know. I mean, obviously they look this stuff up and they're like, we know we're appropriate for treatment. I want treatment. So it becomes a a really difficult discussion around what is your risk. Goes back to the same idea. And what's the risk of a patient like this? If you do the AJCC3As, it's 12% risk of death over 10 years.
In 10 years, and that's coming up, right? So tumor burden is still important, is still an important risk factor. It's important to understand they weren't included in the original trials and probably have a better outcome. Now, if the sentinel node had 2 millimeters of melanoma in the lymph node, then they fit into this trial, right? So it's someone who you might consider, even though they're stage 3A, right? So this is the person who might meet your
yeah, I tell
threshold.
patients that the 12%, like if you're like the original patient, is probably less, right? You're probably 8%, and if you show up like this, it's probably 16. So.
And in the United States, it's important to recognize that BRAF/MEK is an approved adjuvant therapy for patients with stage 3 disease, but we don't have that in stage 2 disease. So that's another reason why people are often sent to us to have the sentinel node, because if they have stage 3, it's a discussion BRAF/MEK versus immunotherapy. If it's stage 2 or stage 2 unknown, it's only immunotherapy, right? So it's an important thing to do, and we'll go through some of this data as well. And do you prefer combination adjuvant immunotherapy in advanced stage 3 disease? Are you there yet?
Well,
No.
I think that's when Dr. Wargo is going to
Yes,
tell us, because
please.
advanced will probably be clinically detected, so potentially
be.
appropriate for
Right,
neoadjuvant.
the whole discussion of neoadjuvant. Okay, so getting to some of the data that we were hinting at here is survival for stage 3. So as you noted, the top line, stage 3A, 10-year survival is 88%. It's pretty good. 5-year survival is 93%. And then all the way down to stage 3D, it's really pretty bad, 32 to 24%. It's actually worse than this. I mean, relapse is actually much higher than this, right? Some people are rescued. So in these things, the survival doesn't mean these people aren't going to have events. It's just that we can rescue some of these people, or particularly the stage 3As. And so this is an update from the Checkmate 238 trial, looking at adjuvant IPI and Nivo in resected stage 3 patients. You can see now with 60 months of follow-up, the relapse-free survival persists. This really, I think, continued to support the superiority of Nivo over IPI as an adjuvant, and also with less toxicity, which we're not really showing here. But and again, with the Keynote 054, updated relapse-free survival, again, resected stage 3 melanoma, Pembro versus placebo. Now with a longer follow-up, you can see how many people are out there till 5 years. Pretty impressive, 55% versus 38% at 5 years. And in addition, as you noted, the importance of distant metastasis-free survival also is pretty impressive, with 61% versus 44%. So this is continuing to show the benefit of adjuvant therapy in stage 3 disease. And the guidelines have been updated to reflect this. So this is our NCCN guidelines, which basically show anti-PD-1 therapy or BRAF/MEK as a preferred option for patients, all with category 1 evidence. The data for resected stage 3 in transit disease is not as clear. Not all the studies actually included in transit. In fact, many of them actually excluded them from their trials, but it is used. They do qualify. And then just to highlight the fact, again, as seen in stage 2, the effect is both in BRAF positive and BRAF negative, or BRAF mutated and non-mutated groups. So it's an option. Immunotherapy is an option for patients who have a BRAF mutation versus not. And I think, yes. And we have also, this is our data on the Combi-AD, which was adjuvant BRAF/MEK for relapse-free survival in stage 3 mutated melanoma. So I think it's a big discussion, right, with Nancy about in adjuvant therapy, with the risk of long-term side effects or autoimmune side effects that could happen versus, if someone's BRAF mutated versus just taking BRAF MEK. Now, in stage 4 disease, there was a DREAMseq trial that showed that there was improved survival for patients who had a BRAF mutation who took immunotherapy up front. So do you translate that into the stage 3, or do you think it's not?
No, I mean, it's really cool to see that at 5 years, you see that 55% for dabrafenib, trametinib, 38% for placebo, identical numbers to what you showed for Pembro and in Keynote-054, the exact same numbers. So I don't think that the translation of DREAMseq is the same. This is an entirely different population. Maybe it works differently, obviously, because it kind of eradicates every last tumor cell, like dabrafenib, trametinib, almost the way chemotherapy works in other cancers. So I think efficacy is equivalent from my perspective.
It's really interesting, and just to highlight, right, these patients only got treated for a year, and yet you were seeing separation of the curves for much longer. And you think of other diseases where we have, for example, imatinib and GIST, for example, the curves come back together once you go off the medicine, but we're not seeing this in melanoma. Okay, so is there a role for adjuvant dual checkpoint blockade? This was, the Immuned study shown on the left. Was a smaller study of 167 patients, and it looked at resected, basically stage 4, but advanced stage 3 too, I believe. And it was Nivo-Ipi versus Nivo versus placebo. So surgical resection, don't do anything versus give some adjuvant therapy. And there certainly seemed to be a large signal for Ipi-Nivo in this study versus Nivo alone. It's a little bit complicated because, although they tried to correct for the population, I think there could have been differences. Or the other thing that you could say is that some people maybe with a more resistant tumor might benefit from the Ipi-Nivo, and certainly there's things looking at that nowadays. But in any case, the checkpoint 915 had a much bigger N, as you can see, 1,800 patients, and looked at Nivo-Ipi versus Nivo alone and really didn't see a strong signal in this population.
And Charlotte, if I make the point here, just the Ipi dose is so different between those two trials, right? So it's 1 mg per kg for Q6 weeks with checkmate 915. So I think we kind of chickened out and used the easier, less toxic regimen. Immuned, because it's a much higher risk population, I mean, look at that placebo. They're like less than 20% because they're stage 4. The German group did the full dose, high dose, 3 mg per kg of Ipi for 4 doses, like the real deal. And that's maybe underlying some of the benefit there.
Yeah. Okay, so looking at newer immunotherapies, one is LAG-3. This is another checkpoint pathway that limits the activity of T cells, and its receptor, like PD-1, is overexpressed or co-expressed on TILs in melanoma. But there's really 2 ways that we've seen this. Number one is using it in patients who are naive to immune therapy, as shown on the top here, and LAG-3 in combination, as we'll show you. Inhibition can be used for better anti-tumor responses. So we'll show you some data on that. But also, studies have shown that patients who are on immunotherapy who are resistant, LAG-3 is actually a biomarker of resistance, if you will, in some of the peripheral T cells, et cetera. So this idea that it could be used as second line in acquired resistance along with other checkpoint inhibitors is also something that's being looked at. So this is a study from my colleague over here, led by him, looking at PD-1 and LAG-3 combination in metastatic disease. And you can see that this has an impressive, again, for stage 4 patients, Nivo and relatlimab, which is the anti-LAG-3, has improvement over Nivo alone, and this is sustained even farther out. But most importantly is the reduction in toxicity seen compared to Ipi-Nivo, which has a very, very high toxicity rate. And so now it is being assessed in the phase 3 trial in resected stage 3. So these are patients with stage 3, again, greater than 1 millimeter tumor burden, or other melanoma patients, and they're being randomized to either Nivo relatlimab or Nivo alone, and treatment for a year. Okay, what about the individualized neoantigen therapy, or RNA vaccine, in combination with PD-1 inhibitors? So one of the things you're going to hear from Jen is that neoadjuvant therapy is better because you have the tumor in situ, and that gives the opportunity to educate the immune system at the time of checkpoint inhibition, where you're releasing the immune system against the cancer, and get better responses. And when we're giving adjuvant therapy, most of the tumor is gone. So you're just relying on some cells or immune cells that are around that you can actually still activate. So this idea that if you take the tumor out and now you can actually give a boost to the immune system to try to get your immune system to recognize specific things about your individual tumor is through this vaccine. And this really amplifies the technology that's been around for a long time, but was then turned around quickly to generate our COVID vaccines. So in the first sense, think about it in the sense of a patient. Their tumor is taken out. They sequence the tumor to look for what neoantigens are in the tumor. Again, this is on a very individual level, comparing for HLA, predicting which neoantigens could bind to which HLA proteins. Then they synthesize these peptides and encode them in an mRNA vaccine, and they had up to 34 neoantigens that were done. This is an individual for each patient, manufactured and administered. And remarkably, they did this over 6 weeks, and part of this trial was actually done during COVID. So just to highlight and remind people that basically the RNA technology was really held back for many, many years because RNA, as you can imagine, is something that is recognized by the immune system, and they had to find ways to package this and then create it so that it can be ultimately expressed and be something that can ultimately your immune system can see, and it's quite effective. So in this trial, what they did is they took resected patients with stage 3 or 4 melanoma, patients who underwent a surgical resection, obviously a complete surgical resection, and they stratified them to get pembro alone or pembro plus this RNA or individualized neoantigen therapy. And the primary endpoint was relapse-free survival, and the other endpoints that you see here. So it was designed with an 80% power to detect a hazard ratio with a one-sided alpha of 0.1, which has been some criticism from the trial because maybe not the most robust requirements. Nonetheless, this data has recently been reported, and you can see here, this was a randomized phase 2 trial, that there is a signal for improved relapse-free survival combining this personalized vaccine with pembrolizumab versus pembro alone. And so you can see here, this is over our follow-up. And so the hazard ratio was here, so it's very encouraging. And this has now moved into a phase 3 large multi-institutional trial that's going on around the world, and I think we'll have a better answer with many more patients. But it's certainly quite exciting, and I think academically, makes sense. So this individualized treatment, of course, is very, it has side effects that are similar to any vaccine. If any of you have gotten the COVID vaccine, you can see fatigue, injection site pain, chills, no grade 3, 4 reactions related to it. So it's well tolerated. Okay, other novel combinations are TIGIT and PD-1 are being assessed in the adjuvant trial. This is, again, patients with resected melanoma, stage 2B/C or 3 or 4. So as you said, expanding the population a little bit. And it's a pembro alone or the combination. And I just heard that it finished accrual last week, so we will have some interesting results coming, which is
Huge
super
trial,
exciting.
though. 1,500 patients.
1,500 patients, yeah. Very exciting. So, okay. And then lastly, there is the potential for local administrations or sub-Q administrations of immunotherapies. And this is really interesting. And so you can see here, there's sub-Q versions of nivolumab, Nivo-Rela, Pembro, which are being studied in different cancer types. And it's a very fascinating idea, and surgeons may be involved in some of the sub-Q administrations of these agents as we move forward. Okay, Dr.
All right,
Wargo.
so back to our follow-up
Yeah.
poll. So audience participation now. So when deciding on whether to pursue adjuvant immunotherapy for a patient with resected stage 3A melanoma, what factor would now most likely inform your decision to recommend treatment? 1 would be no factors. I would not treat stage 3A. 2 would be BRAF status. 3 would be tumor burden of over 1 millimeter tumor in the node. 4 would be tumor burden of 1 millimeter or higher in the node. And 5 is I'm not sure. So go ahead and
Isn't
vote.
this 3 supposed to be less than?
Yeah, I think 3 is less.
Maybe.
Sorry.
I don't know.
Arrow's
They
pointing
both say
the
the
wrong
same
way.
thing.
Yes, I
3 and
know.
4
As
say the
I
same
was
thing.
reading that, I was like, this seems awkward.
Sorry.
So make 3 less then.
We won't fail you if you choose one of those.
That's right.
There we go.
All right, so tumor burden of at least 1 millimeter or higher in the node, I think is the consensus.
I mean, I always say that the pharmaceutical companies wanted their drug to work, right? So they excluded the lowest risk
Yeah.
patients.
Yeah.
Yeah.
Yeah, I mean, you know,
Yeah.
right? They wanted to show efficacy in a good way, right? So,
Yeah.
yeah.
The one thing that I say in this setting is kind of you made such a great point for BRAF, and I, a lot of the times those patients show up without knowing the BRAF status in the adjuvant setting, and I feel strongly about that. These patients need to know. And a lot of the times immunotherapy just started because everybody watches it on TV, right? But they really need to know just so that they know what options are available. And if a lot of them still choose immunotherapy, but that should be kind of more informed.
So is it for you individually, is it a patient who's got underlying autoimmune disease that makes you think of BRAF? Or is it just
I actually
discussion?
no, it's a long discussion.
Yeah.
It's 45 minutes with every patient, but I refuse to make the final decision on adjuvant until I get the BRAF status.
Yeah.
That's kind of how it goes. And my experience is, the younger patients are the ones that will say, I'll probably do the targeted therapy. So.
Yeah.
All right. So final frontier for the evening is the neoadjuvant immunotherapy story and surgical and medical oncology collaboration. And I'll present.
You're going to have to read your title.
Yeah.
Oh, no. The Arlie Clark Endowed Professor of Surgical Oncology at MD Anderson, but thank you. I appreciate it. So here is our case again. So Nancy now is 48-year-old woman, now presents with the melanoma of the upper arm, this time 4 millimeters, non-ulcerated. And this time she actually has palpable nodes. And she actually has PET avid nodes when you go ahead and image her. She has no evidence of distant disease. She is BRAF mutation positive and currently is stage 3C. And so for discussion, really the points are, what's the best choice here? Does she have upfront surgery and adjuvant therapy, immunotherapy that is? Or do you treat her with neoadjuvant immunotherapy? And if so, do you treat her with neoadjuvant immunotherapy, or should you treat her with neoadjuvant BRAF and MEK inhibitors? And if you treat her with immunotherapy, is it single agent or combination? And boy, we've come a long way. You'll hear a little bit about this. It's complicated, right? It really is. But we'll talk a little bit about the data, and hopefully you'll come away with a better understanding and a better idea of how to treat patients like this. And so the topic of adjuvant versus neoadjuvant therapy, we've been discussing this for several years. There was preclinical evidence that neoadjuvant is better than adjuvant. And really what's the proposed rationale for neoadjuvant is that you actually have a tumor in place, like Charlotte was saying, that you can give checkpoint blockade, auto-immunize with that tumor in place, and then after you resect that tumor, you still have immunologic memory and better efficacy. With the adjuvant, you remove that tumor and you're relying on much less tumor burden, if any at all, to educate the immune system. And so the hypothesis going into this is that neoadjuvant would be better simply because of the aspect of kind of an auto-immunization, if you will. And when we look at it, neoadjuvant actually does perform quite well for both immunotherapy as well as targeted therapy. And this is data from a recent publication in Nature Medicine by Alex Menzies and the group at the Melanoma Institute of Australia in collaboration with us as well, all of us. And basically showed that if you treat patients with neoadjuvant immunotherapy, either anti-PD-1 monotherapy, anti-PD-1 plus anti-CTLA-4, if patients have a pathologic complete response or any response whatsoever, they actually have very good survival rates. Whereas if they have no response, they actually do poorly or no pathologic response. Now contrast this with neoadjuvant targeted therapy, okay? So if you treat patients with neoadjuvant targeted therapy, if they have a complete response, 0% viable tumor, they do well, but not great, right? Some of those patients still relapse, often in the brain. And if they don't have a complete response, so if they have any viable tumor whatsoever, they actually do quite poorly. And so what's the answer here? Is if the patients can tolerate it, neoadjuvant immunotherapy is superior to treatment with neoadjuvant targeted therapy. Now, after doing some kind of discovery studies, clinical trials, there was a large study that was performed, SWOG 1801, through the Southwest Oncology Group, where neoadjuvant versus adjuvant pembrolizumab was shown to prolong event-free survival versus adjuvant pembrolizumab alone. And so basically what they did is treated patients with neoadjuvant versus, with adjuvant versus the adjuvant only for the same amount of time. And in a median follow-up of 14.7 months, the neoadjuvant and adjuvant group had a significantly longer event-free survival than the adjuvant only. So again, we're kind of seeing this borne out in this cohort of patients. And the event-free survival at 2 years was 72% in the neoadjuvant and adjuvant and 49% in the adjuvant. So does neoadjuvant immunotherapy work? Absolutely, yes. Now, how about the benefit of neoadjuvant therapy across the subgroups? And that held, right? So in every subgroup tested, there was really benefit. And so there's not a particular subgroup that might benefit more, at least per this data. And when we actually look at the rates of pathologic complete response with neoadjuvant and adjuvant strategy, what we find is that pathologic complete response rates were actually quite high, and the patients actually did quite well. If they had a pathologic complete response, did quite well. If they had a partial response, did quite well, or a near complete response versus a partial response. And it's only, again, those patients who don't have any response whatsoever that don't actually benefit much, but some of them still do. And the caution is that there remains a need for standardizations of definitions and assessment of pathologic complete response in order to inform neoadjuvant treatment strategies and selection of either single agent versus combination therapy. And so, we've as kind of a collective, the International Neoadjuvant Melanoma Consortia, we've put together. We've actually done a lot of work with this, with our pathologists, and have really attempted to define major pathologic response or pathologic assessment of resection specimens after neoadjuvant therapy has been made. So a pathologic complete response means that there's complete absence of viable tumor in the treated bed. There's, for a major pathologic response or a near path CR, there's less than 10% viable tumor in the treated bed, and this may represent a meaningful endpoint in the context of neoadjuvant immune checkpoint blockade. We see that they pretty much mirror each other. There's near complete response versus a complete response. And partial response is less than really the non-response actually is less than 50% of the treated bed. And so, really, but I think we need to kind of come back to this. There are some differences between targeted and immunotherapy. Now, we did run an interesting study where we looked prior to the initiation of SWOG 1801, we designed a clinical trial to ask the question if neoadjuvant treatment with anti-PD-1 monotherapy was equivalent to treatment with combined immune checkpoint blockade. And so what we did is we took patients with local regional metastatic melanoma with stage 3 or oligometastatic stage 4 disease and randomized them to either get treatment with neoadjuvant Nivo or anti-PD-1 monotherapy versus treatment with neoadjuvant CTLA-4 and PD-1 blockade. And note we did IPI-3 Nivo-1 on this study. And we then restaged, did surgical resection, and everyone was treated in the adjuvant setting, and then did clinical and radiographic follow-up, also collected longitudinal biospecimens in the context of this trial. And what we found when we did this study is we found that patients who received treatment with combined immune checkpoint blockade targeting CTLA-4 and PD-1 actually had much better response rates. Okay, we actually saw, an overall response rate of that we tripled the overall response rate and nearly doubled the path CR rate, but it came at a cost of a lot more toxicity. So this brings us then to addressing toxicity through the flipped dosing. Okay, so again, I mentioned that we used IPI-3 Nivo-1 in those studies, and people have now gone on to actually investigate whether or not we can actually use a different dose and regimen. And one of the best studies out there is this Opus and Neo study, which actually identified neoadjuvant IPI-1 Nivo-3 as the optimal treatment scheme. And so what they did is they took, again, patients with bulky stage 3 melanoma, randomized them to 3 arms, either 2 doses of IPI-3 Nivo 1, 2 doses of IPI-1 Nivo 3, or sequential IPI and Nivo treatment. They were then taken to surgery and followed, and what you see is that the pathologic complete response rate was actually pretty equivalent between the conventional IPI-3 Nivo 1 dose and the IPI-1 Nivo 3 dose, but the toxicity rate was much lower in this IPI-1 Nivo 3 dose. So this is kind of the flip dose. We call this flip dose IPI-Nivo, and this is really kind of what we use in the clinic these days. You can see that the sequential treatment was actually worse. And flip dose does appear to maximize efficacy and to limit toxicity of neoadjuvant immunotherapy. And so again, IPI-1 Nivo 3 is kind of the secret sauce, if you will. And the follow-up for this is pretty robust. And so this is the Opus and Neo follow-up after 2 years. You can see, again, patients actually do quite well with this. And after a median follow-up of close to 50 months, median RFS and OS were actually not reached. And so next, really the question is, can we actually omit therapeutic lymph node dissections in these patients after neoadjuvant treatment, right? And this was a topic of a great debate earlier, which Charlotte did a great job really posing. But this Prado study actually helped to highlight this question, right? And this is the personalized response-driven adjuvant therapy after combination of IPI-Nivo in stage 3B, 3C melanoma. And so what they did in this study is actually took patients with stage 3B and 3C melanoma who were actually either de novo or recurrent melanoma, and actually treated these patients with 2 courses of IPI-1 Nivo 3. And then if the patients had a pathologic complete response or a near path CR, they did not undergo completion lymph node dissection and were merely followed up with CT scans every 12 weeks. However, if these patients actually had no pathologic response, they actually underwent a lymph node dissection and were treated in the adjuvant setting with nivolumab. And then were followed. And if they had a partial response, they were also treated with a completion lymph node dissection and just followed. So what did we learn from this study? Well, here's, again, robust relapse-free and distant metastasis-free rates at 2 years for the total cohort. So you can see, the patients actually did quite well. And patients with a major pathologic response did have this high RFS and DMFS rates, okay? Now, what we've learned from this, the quality of response may actually drive subsequent treatment decisions. And so Prado actually did confirm the safety and high pathologic response rates of neoadjuvant IPI-1 and Nivo 3 observed in the previous Opus and Neo study. Omission of therapeutic lymph node dissection and omission of adjuvant therapy in patients with major pathologic response were associated with better quality of life and resulted in high 2-year RFS and DMFS rates, but there were nodal recurrences, right? And we do need more trials and data. Patients with partial pathologic response do seem to have higher relapse rates than suggested previously, might actually benefit from additional adjuvant therapy, and addition of adjuvant systemic therapy with radiation with patients who do not have a response seems to improve the 2-year RFS compared with historical data. And Charlotte, any insights from that great debate earlier?
This is a surgical debate. I had to debate on the full lymph node dissection. I think it's just important to recognize that the Prado trial had about 100 patients in it. Its endpoint was looking at relapse-free survival. One of the co-endpoints was relapse-free survival in patients who had a major path response, so just had the index node removed. And it didn't meet its pre-specified endpoint there. So in other words, the recurrence rate in the nodes from Opus and Neo is 2%, and it went to 7% in this trial. Honestly, a lot of those patients were rescued with just a simple re-resection, et cetera, but the nodal recurrence rate is higher. So I think we need to understand more about that, and it's a discussion with the patients, because patients also have to understand that if you're going to treat them according to this protocol, if you just resect their first node, you have to understand that they're going to come back for another resection if they don't have a major path response. So there's a lot here to digest with the patients and everything else.
I might add that,
Yeah.
also, I think Christian Blank, who designed the study, was
Yeah.
a bit too optimistic with that primary endpoint.
Of
He's
course.
like, no recurrences will ever happen.
Well,
that was
because in the
the
Opus-
goal was that high.
Okay,
it
the
was
Opus and Neo trial, everyone had a therapeutic lymph node dissection,
Yeah.
and the recurrence rate was 2%. So he used that number, to formulate his Prado, and it was very optimistic. I agree, but it did go from 2% to 7%. Both, small numbers. I think the major path responses in the Opus and Neo is maybe like 52 patients, and then the major path response in this is 60 something. So
pretty
it's a
close.
small group of patients, but yeah.
All right, and a big question, going back to biomarkers, can biomarkers actually help guide neoadjuvant immunotherapy? And so in Prado, baseline interferon signature or PD-L1 expression seemed to be a biomarker for long-term event-free and overall survival, whereas TMB was not associated with overall survival. Combination of baseline interferon signature, PD-L1 expression, and TMB did seem to further distinguish patients with event-free survival benefit, which they classified as the triple high versus no benefit, which were the triple low patients with those biomarkers. And how about additional trials? So this is the NADINA trial, which will test neoadjuvant ipi-nivo with standard adjuvant nivo in macroscopic stage 3 melanoma. And so in this study, the key eligibility criteria are for patients with resectable stage 3 melanoma with at least one macroscopic pathologically proven lymph node metastasis. And they'll undergo 2 courses of ipi-nivo followed by a therapeutic lymph node dissection. And if they have a major pathologic response, start follow-up, whereas if they have a pathologic response or non-response, they'll get nivo in the adjuvant setting. And this is compared to patients who undergo a therapeutic lymph node dissection followed by treatment with adjuvant nivo.
So this is we already have the SWOG trial,
Yeah.
right, of PD-1 alone showing a benefit, and now this is looking at ipi-nivo. So you think if this is positive, the results are going to come out at ASCO. Will this seal the deal that most patients will get neoadjuvant? What do you
I mean,
think?
it's randomized evidence. One would argue
Well, so
for
is the
S18,
SWOG.
S1801 was randomized phase 2.
Yes.
The
Yeah.
naysayers will say it's a randomized phase 2. You have
Yeah.
to take that into account. But that's a massive benefit.
Yes.
And this is a phase 3. So if
Yeah.
positive, I think no place for argument there. I do think that S1801 proved that neoadjuvant's better, but didn't really come to a conclusion of that's the best regimen.
Correct.
Right.
So
Correct.
I
Right.
think this would help.
Yeah, and from a practical standpoint, can you speak to, a patient comes in, though FDA, is this an FDA-approved indication? Yes or no? No, currently, right? But, can you get insurance, approval for these? What's the right thing to do for the patient? If you can kind of touch on that.
Yeah, I mean, you're still going to present probably on the PD-1 lag as well, which kind of is a
Yeah.
discussion to be had. I mean, it's toxicity versus benefit, but at least at MD Anderson, it's not been hard to get insurance approval because these are, stage 3C, 3D. These are, palpable, clinically detected metastatic disease. So I don't know that the nuance of this is, not distant metastases kind of, works for us at least. That hasn't been hard to get approval. But it is a question, at this time, this is an experimental approach. Here's our experience with it. This is what I would recommend. And, some patients may just not do it, but most patients do.
Yeah.
And then I will say that our surgeons at MD Anderson, if their patient shows up, they refer them to me and they don't let them go under the knife until we have that discussion.
Yeah.
So I think that's important.
Okay. All right, so how about the next step in combination therapy? So neoadjuvant PD-1 and LAG-3, discussed this in the metastatic setting, but can you actually use this in the neoadjuvant setting? And so nice study done, collaborative study between these 3 people on this stage here and their respective institutions. Took patients with resectable stage 3B, 3C, 3D, or oligometastatic stage 4 melanoma with an ECOG performance status of 0 or 1, and no prior history of treatment with anti-PD-1, anti-CTLA-4, or anti-LAG-3, and then treated those patients with Nivo-Rela and did a surgical resection, treated them in the adjuvant setting, and followed. And what did we find when we ran this study? Well, we found that treatment with neoadjuvant nivo and relatlimab is an active approach with a high pathologic complete response rate. So you can see that 57% complete response rate with an additional 7% of a near path CR and some partial responses, non-response rate of only 27%. And you can see if patients have a pathologic response, they actually have a lot of benefit from this. And really one of the most striking things about this trial was that the toxicity rate was markedly lower in the nivo-rela compared to ipi-nivo. So. Now, how about additional combinations? So PD-1 and TIGIT, again, going to be used in the neoadjuvant setting. This is a trial that's underway here with eligibility, so at least 18 years of age, resectable stage 3B, 3C, 3D melanoma, randomized to either Pembro plus TIGIT versus Pembro. Sorry, I'm looking at this here.
Don't try to
yeah, I know. It's hard to say that. Yeah,
non-comedic
exactly.
virus.
Versus Pembro alone. And then they undergo surgery and are treated in the adjuvant setting. Now, how about the activity? And so there is good activity. Early results suggest promising efficacy, safety of Pembro plus this TIGIT inhibitor. Further evaluation of the neoadjuvant and adjuvant PD-1 plus TIGIT therapy is warranted. So now, where have we arrived? So neoadjuvant therapy and guidelines. So thank goodness, the NCCN now recommends neoadjuvant options when appropriate in settings such as stage 3 clinically positive nodes, stage 3 clinical satellite or in-transit disease, as well as nodal recurrence. Preferred regimens of Pembro or ipi-nivo. Other recommended regimens include nivo and relatlimab, and used in certain circumstances, certainly the BRAF/MEK inhibitors, Dabtram, if these patients have a BRAF mutation. And so the follow-up poll. So we'll go back to this follow-up poll. So consider an adult patient with melanoma of the upper arm who presents with confirmed stage 3C BRAF wild-type disease. Additional assessment confirms palpable nodes. How would you now manage this patient? So number 1, would you give them adjuvant PD-1 therapy? Number 2, would you give neoadjuvant PD-1 surgery, then adjuvant? Number 3, neoadjuvant ipi-nivo, then adjuvant therapy based on response. Number 4, neoadjuvant PD-1 LAG-3, then adjuvant therapy based on response. Number 5, neoadjuvant BRAF/MEK surgery, then adjuvant, or 6, I'm not sure. So the choice is yours. All right, so there's a fair amount of people using neoadjuvant CTLA-4 and PD-1 blockade, some monotherapy, also the PD-1 LAG-3. So I think all appropriate choices.
So it seems like more people switch to combination therapy on the post.
Yes, yes. Converts, yes.
And hopefully Nadina will confirm this.
Yes, exactly. All right. Okay, and so let's go back to our patient Nancy again. So this time 4 millimeter non-ulcerated melanoma of the upper arm. She has palpable disease, detected, PET avid, no distant disease, BRAF mutated stage 3C, assuming neoadjuvant therapy and surgery followed by adjuvant PD-1. So how about if she then relapses? So what are the options after progression on anti-PD-1? Do you give her dual checkpoint blockade? How about TIL? So we will touch on all of these. So I'll show a little bit of the data first. So what happens after PD-1 progression? So this is a tricky one, and I think was she BRAF? I'm trying to remember if she's BRAF mutated.
She's going back and forth.
Yes, she is. I know.
But if she was BRAF mutated, that would be another option.
Yes,
right, to add that
exactly.
in. Right.
But how about after PD-1 progression? And autologous TIL therapy is now an option, okay, recently FDA approved. And so what is TIL, or tumor infiltrating lymphocyte therapy? So certainly what you can actually do is resect a tumor, harvest that tumor, then grow it in interleukin 2 or T cell growth factor. That will actually, the T cells grow and kill off all the tumor cells, and you can give that back as a product, right? And so what you do in this scenario is actually, intake the patient, they get a tumor tissue procurement through a surgical resection. Sometimes can be done in the office, I can say. They get treated with a non-myeloablative lymphodepletion with cyclophosphamide and fludarabine or Cy/Flu. Then they get the infusion of their TIL, and then interleukin 2 administration up to 6 doses, still intravenous, testing sub-Q regimens, I know, and then discharged, okay? Now, we know that tumor resection can be skin, lymph nodes, liver, lung, peritoneal, musculoskeletal, breast, other organs. They tend to not like the GI tract for reasons of contamination. And as of February 2024, it's now FDA approved for adult patients with unresectable or metastatic melanoma, previously treated with PD-1 blocking antibody. And if BRAF V600E mutated, a BRAF inhibitor with or without a MEK inhibitor must have been given prior to treatment with TIL. And there was a randomized controlled trial of checkpoint blockade versus TIL, where a total of 168 patients, 86% of those with disease refractory to anti-PD-1, so take it with a grain of salt, not all of them were refractory, were assigned to receive TIL versus treatment with ipilimumab. And what they saw is that, 89% were treated with PD-1, 20 adjuvant PD-1, 62% were frontline, and 11% had no prior treatment. Now, what did they find? So basically, TIL improved progression-free survival compared with IPI in the post-PD-1 or the PD-1 refractory setting. Okay, and you can see, so here's TIL, here's treatment with IPI. And the important things here that harvesting the tumor, you have to really prioritize the most easily accessible site with low morbidity, expedite wound healing, and because patients are going to go on to this intense chemotherapy regimen. And the tumors do have to be handled sterilely throughout the process. It is a cell therapy, and it's subject to rules of cell therapy and under the domain of CLIA. Now, how about the safety experience with immunotherapy in the neoadjuvant setting? So we know, this was a paper that we put out a few years ago, toxicity of immune checkpoint inhibitors, considerations for the surgeon. So we know that these different aspects of toxicity can occur. Here's pulmonary, GI, endocrine, renal, GI, or colitis, and skin rash. So the skin rash tends to occur early. You can see the tempo of each of these, but it's really important to be aware of these. Adrenal insufficiency is also another big. You've probably seen a fair amount of this too, huh?
Yeah, I think this is really important for the surgeons. And you see your patient in the office, they say they're tired, just check. I just check TSH, free T4, and a cortisol, random. Because it's just so complicated when they get to the OR and they're, adrenally insufficient. And you don't realize it at first, right? And I think our breast colleagues are even seeing this. If any of you guys do breast as well, they're seeing a lot of this now because of the Pembro is approved in the neoadjuvant setting.
Yeah.
And by the time they get there, it's 12 weeks later. So, especially in the breast world. So you can see the purple. That's when these endocrine things are coming out. Yeah. So it's pretty easy to screen for, and just because once they go to surgery or have something, it's hard.
Yeah.
Yeah. The trick with adrenal insufficiency is to think about it.
Yeah.
They are the only times that you get burn is when you don't think about it.
Right.
Then find out later. So always think about it.
I've seen patients who've come in with a fever, 103, and it was adrenal insufficiency.
Yeah.
Yeah. So especially in the setting of surgery, you're always thinking infection, and sometimes it's adrenal insufficiency.
Yeah.
It's always the medical oncologist's fault.
No.
And in Opus and Neo, again, there's a wide range of toxicities. Again, flip dosing schedule was used, and that really does reduce the toxicity. And the majority of toxicities occurs in the first 12 weeks. Only 4 patients develop their first high-grade immune-related adverse event beyond 12 weeks. But you do definitely have to think about it. Now, how about the safety experience with neoadjuvant PD-1 LAG-3? So again, better tolerated. Very fewer grade 3 or 4 adverse events, and really much safer in a lot of ways, certainly than Ipi-Nivo.
Yeah, I mean, I'd like to highlight that because the low-dose Ipi/Nivo, it's so much better than the high-dose. I mean, Jenny showed the way we learned it the hard way at MD Anderson was when we did high-dose Ipi/Nivo, it was 73% grade 3/4 toxicity. My patients had, 3 different toxicities before they can go to the OR. Low dose is only 20%, but that's still 20%. Nivo-Rela, when we ran the study, 30 patients, but it was 0. Not a single one of them had toxicity in the neoadjuvant phase. So, I mean, I think it's aspirational. I can't assume that, it's never going to happen, but it's still a lot less than 20%.
All right, and then SWOG 1801, I think similar rates of high-grade AEs in either group, placebo, versus, or the adjuvant versus neoadjuvant, pembro. So, and disease progression or toxic effects in inability to undergo surgery occurred in less than 10% of patients. So, all right, so let's move to the Q&A. Okay, so we do have, should we go first to live Q&A? Or I'll kick it off with a question. So how about what is the best sequence for IO in adjuvant treatment?
Sequence?
Yeah. Is there a role for sequence? Guess if you think of progression on.
Yeah, so that's a great question, and the fact that obviously adjuvant really helps, but we still have about 40% of patients can recur on adjuvant treatment, and so after adjuvant treatment, it's always a question of what's the pattern of recurrence and whether it was during or shortly after treatment, which we actually consider. As you know, with the SITC definitions of resistance, we consider that primary resistance. So it's as bad as being first-line metastatic and progressing on treatment. But if you recur, 6 months, I don't know where that comes from, but let's say a year or 2 later, you can think that the single-agent PD-1 might have had an impact, and so there's a chance that you could revisit, single-agent. Now, in the metastatic setting, obviously, we're using combinations anyway, so it kind of goes back to using combination therapy. But if it's still localized disease, I think this idea of, potentially coming in with neoadjuvant combination before we send it to surgery.
Yeah, okay. And then...
and it's just to highlight that, right? Because we showed some data of adjuvant combination therapy in stage 3 resected disease. So are you more likely to just give single agent with the idea that then you save your combination for later, or the potential for neoadjuvant even for later?
The current approvals are still single agent, so the chance of some of our patients that are on the trials with combinations coming back with recurrence, it's still, some of them are blinded, so we haven't faced that as much, but if they get approved, it's going to be a problem. When to use the combination will become equivalently difficult.
Here's a scenario for you. This is a patient of mine. So, she had a wide excision sentinel node, positive sentinel node, went on to adjuvant PD-1, relapsed, got treated with neoadjuvant Ipi/Nivo, progressed, got resected. Now what do you do? What would you treat her with?
Pray for BRAF.
No.
Wait, what was her
Wild
path
type.
response? What was her path response?
Technically a non-response, it was like 51% viable tumor, So what do you treat her with in the adjuvant setting?
I mean, there's no indication for anything at this point.
Yeah.
You just have to observe and, as I said, pray, which I don't do a lot of.
Yeah. Okay. All right. And would you ever consider treatment with Ipi/Nivo in the adjuvant setting for someone like that?
So the Immunet study was really impressive, right? And so if I get a situation like this where so if it's single agent recurrence, I consider treating with, if it's a long recurrence and it can be just one lesion and can be resected, I have definitely done the Immunet regimen, the 4 doses of high dose of Ipi/Nivo, but not low dose. And it's a very specific setting. And if a patient, like you mentioned, had already received neoadjuvant Ipi/Nivo, then you're kind of, at that point, you're just going to have to observe and see what happens.
Yeah, okay. All right, another question from the virtual audience. What's the importance of sentinel node biopsy nowadays? Charlotte.
Well, hopefully that was a question before we started talking.
Still important.
Yeah, still important. So as we showed you, sentinel lymph node, in a nutshell, improves your staging. It is validated to, as a staging better than the gene, descriptive models at this point. We would love for them to be able to discriminate better and not have to do a sentinel node on everyone, but we're not there yet. And if it provides a benefit. It's a small number of patients, but probably more we saw from the Australian group today in early disease rather than later disease.
There's another good question on techniques to be applied to lymphatic basins post neoadjuvant therapy.
Should I take that one?
Yes, please.
No.
Oh, so I think the question here is, after neoadjuvant therapy, do you need to just take out one node that you see or the two nodes you see, or do a complete lymph node dissection? And once again, I think this is a long discussion. We debated this today with the patient. I personally believe that the patients who you can probably select for this are people who have a single node on imaging where you're seeing a radiologic response. Those are probably your good actors, and so you could certainly do that. People who have multiple nodes, I still talk to the patients about it, but I really favor in those people just completing the lymph node dissection, getting all the information, and not having them to go back. I think we can't underestimate the fact that people are getting an index node, then they're getting a node resection, then they're coming back for a therapeutic lymph node dissection. And so those high-risk patients where it's a high, several nodes on imaging, I think a lot of these patients aren't that excited about it. Many of them had a positive sentinel node to begin with and were on adjuvant, therapy or under observation, and now they're just saying, get it out, and I kind of agree with them. But more to come.
Yes.
More studies are being designed to address this.
Yeah. And how about what volume of tissue is necessary to initiate neoadjuvant therapy?
I mean, I think if you haven't gotten the fact that all three of us here, based on the evidence you've seen, we really love the opportunity to treat in the neoadjuvant setting, especially the fact that in early stage you can use combination neoadjuvantly. So any clinically detected disease is a good excuse, so to speak, because you're going to put those patients in a much better, kind of bracket of outcome. So any clinically detected disease on ultrasound, CT scans, obviously clinical, clinical exam is good enough for me at least.
Yeah.
And in the Prado trial, if a patient has a major path response, those patients had the surgical resection and no further treatment and had excellent survival. So take that patient, they got 2 doses of immune therapy, they didn't get any other treatment for the year, as opposed to people who would have a surgical resection and then get an adjuvant therapy for a year. So I don't know if you guys are de-escalating systemic treatment after yet, but it is an opportunity that's provided for by the neoadjuvant approach.
If we do the Ipi-Nivo, I do stop with the PAS-CR. With Nivorella, I follow the trial we did, which we continued treatment, and that's when we got all the toxicity, by the way. We still got 26% toxicity.
Exactly.
So that's an evolving.
It's an evolving area.
And there was a couple of questions on neoadjuvant selection. When do you go with single agent versus combo? And what potentially would you consider as subsequent adjuvant in either case? Does the choice of neoadjuvant influence what you do in the adjuvant setting? And you kind of just spoke to that.
Yeah, I mean, I will tell you where I used single agent. And my 97-year-old patient, literally, I saw him yesterday, had a singular lymph node in the neck, and I just did 1 dose of PD-1, and we didn't have to do anything else. So, but I do believe in combinations. I think S1801, again, just showed that it's better than doing the single agent as adjuvant, but I do still go with combination in the neoadjuvant setting. You do want that PAS-CR. That PAS-CR is... Those patients look like they're cured, right? 87 to 90%, RFS or EFS. That's fantastic. So if I can get a high rate of PCR, I'm just going to go for it.
Mostly combo, Charlotte, at Memorial?
Combo, I think the patients who are lower, you're worried more about toxicity. We're doing PD-1 LAG-3. And patients who are really old, a single agent.
Yes.
So.
And then there were some questions, I'm going to combine these two, on kind of patients at risk for immunotherapy toxicity, ocular myasthenia gravis. So, how would you manage a patient who's in their 80s, stage 3C, patient has a past history of ocular myasthenia, last episode 40 years ago, otherwise active and healthy? Is immunotherapy contraindicated in those patients? So
I have a patient a specific patient that had just an isolated ocular myasthenia, the same exact situation, and I didn't treat him in the adjuvant setting. He recurred with a singular lung met, so I treated him with single agent PD-1, 2 weeks later, I told him I want to take him home with me because I'm worried about what's going to happen when you do data myasthenia patient. Instead of going home, 3 weeks later, he called me from the ski slopes. And he's like, I don't know, I'm not sure that my eye is doing very well. So, I mean, again, it scared the heck out of me. But I did end up having to give him a short course of steroids. But he did fine, and he's actually, playing tennis now. So, and still skiing really bad places, but that's different.
Here's a good question. Is it standard to order BRAF status on all melanoma primary biopsies? Our medical oncologist doesn't seem to use it there in their initial treatment planning. Like, what are your thoughts on, do you do BRAF on everyone?
Well, stage 2, Charlotte mentioned that we don't have yet any indication for treatment for stage 2, but for stage 3, I consider it an incredibly important piece of information. You really want to know. I go as far as saying sometimes that if you don't know, you're not actually getting appropriate informed consent, because you really have to give a patient all of their options. And if you don't know their BRAF status, they don't know all of their options. So I feel pretty strongly about that.
Yeah. And then, let's see, any rationale for adjuvant BRAF MEK in stage 2C followed by PD-1?
So again, no data in the stage 2 setting.
Yeah,
I mean,
gotcha.
I've had patients with stage 2 with negative sentinel lymph nodes where it's like a large lesion on their scalp, and I've treated with BRAF MEK almost in a neoadjuvant fashion, but this is all just not proven by any data at this point. So you find yourself in those situations occasionally.
Yeah. And then there is a question, can you use the Melanoma Institute of Australia calculator without sentinel lymph node biopsy?
I guess, did you try it yourself yet, the MIA calculator? Because I think the sentinel lymph node not being there gives you just higher points, like it's higher risk.
Yeah, it's higher risk. So you're automatically putting your patient in a higher risk category.
Unknown is
unknown.
the choice, yep.
Yep.
So yes, you can. Yeah, and are you using the MIA model in your practice for stage 2 prediction?
It was published like 3 weeks ago. So
He's starting to.
I want to, but I haven't as much yet.
But I will say, it is very, I will use it, in my clinic, because you just have it pulled up. It's, quick. We did the drop down here, and it took us no time, so I think it's, high utility, gives your patients a lot of information and could help guide treatment.
Should we give people that decided to be in this room?
Yes,
the chance to ask
absolutely.
questions?
Yeah. Any questions from the live audience here? Yes.
You mentioned about the biomarkers which are still in flux. Can you comment on the PD-1, PD-L1 marker, which really bothers me a lot? Why is that we're not using it, since we know so well about the checkpoint inhibition mechanism? Thank you.
That's a great point. The only thing that PD-L1 tells you is a patient is more likely to benefit, but it doesn't. If it's negative, it doesn't tell you that you shouldn't use it. And again, Keynote 054, Checkmate 76K, they did analyze by PD-L1 status, and just like in the metastatic setting, there's increased benefit if you have PD-L1 positive, but you still get benefit if you're PD-L1 negative. So. It ends up being not very useful, and I don't wait for it to make a decision. It's a very different situation than lung cancer.
Great. If there's no further questions, then I think we'll go ahead and wrap up. So please do visit us at peerview.com/melanoma24. Complete and submit your post-test and evaluation for credit. You can download the slides, practice aids, watch the replay of the event in the next 24 hours, and online activity in the upcoming weeks. And thank you very much for your in-person attendance, and for all those online, thank you for your attendance. We really appreciate it, and thanks for spending the evening with us. And go out there and use that calculator. Thank you.